Florence Unno from Seattle. And she's talking about persistent pain following a well-executed PAO.
Yes, good morning. I've been tasked with this difficult subject, which is a little bit of a conundrum because if it's a well-executed PAO and there's still pain, you must have missed something, and maybe the talk is going to concentrate on maybe what we have missed and how to avoid that. So this is right in the subject. This is Kyle. He's a 25-year-old with the non-concentric bilateral dysplasia in the context of Stickler syndrome, a collagen inherited disease. And he's pain-free on the left-hand side after Keith Mayo did a PAO on the left-hand side. So there is no talking him out of doing a PAO on the right-hand side when I see him for pain. And I worry a lot about post-operative pain in Kyle because he's a young, athletic, high demand. And obviously there's a significant arthritis already showing and a poor congruence of the joint. But it turns out that Kyle is not really the patient we need to worry about because he knows at one point or another he's going to get a total hip replacement, so he anticipates recurrence of pain. And yes, he's high demand, but that makes him highly motivated to do everything in his power to beat the odds. In contrast, and I think we all have Zoes in our lives, she's a 24-year-old with bilateral moderate concentric dysplasia, a well-preserved joint, but she comes with a history of failed scope. We don't really know what happened. It was a long time ago. We don't have access to the operating note. And an array of mental disorders, an LNI claim, and on top of it, the response to the intra-articular injection, image-guided or equivocal. So we do our due diligence. Spine consult clears her. Rheumatologists, neurologists clear her, so reluctantly we schedule her for a right PAO. And at this point, we know that not only we own her hip pain, her groin pain, but also her SI joint pain, the medial side dysesthesia that she gets, the foot trembling, and so what. And so the lack of predictability of the pain relief we can bring with a PAO is what is going to potentially make pain management post-operatively difficult. And this is maybe the heart of our problem is what we call the well-executed PAO is our perspective as a surgeon, mainly radiographic, mainly technical, when patients don't really care about what an X-ray look like, and they're going to judge us on their perspective of pain control and function. And so how do we meet those how do we make those circle meet? So beyond a pretty X-ray and a technically well-executed PAO, maybe our role in preventing post-operative pain is to identify patient-specific factors that that could announce post-operative pain and acting on them. The idea that the more we do up front, the less we'll have to scratch our head once pain recurs or persists after the PAO. So this is a 34-year-old high-functioning female who comes for right hip pain, and she has a history of polio quite significantly affecting the same side. So despite, so beyond the technical aspect of a pretty important correction, the anticipated possible pain generator in her are going to be lateral and gluteal fossa pain in the context of weak abductors post-polio. With a weak core and a big correction, we expect that she's going to have a tough time correcting for the hyperlordosis, compensatory hyperlordosis that she had prior to the operation, and that might perpetuate low back pain. Anterior pain is possible. We're going to do a big correction, so pubic repair might be tardy and eventually lead to a non-union that might be symptomatic, and posterior pain is possible as big corrections are associated with extra 6 millimeters about medialization of the joint, leading to possible symptoms related to ischiofemoral impingement. So what can we do? What are the actionable items? So maybe the management of post-operative pain in a well-executed PAO is a lot about acting preemptively. So what can we do? We did intensive PT and in relationship contacting the PT to organize abductor and core strengthening pre and post-operative to correct for lordosis, gait training, abductor compensation of the adductor pull to avoid ischiofemoral impingement as much as possible. At the level of the pubic cut, we try to minimize the potential diastasis at the cut. So with our osteotomy as shown on the white model here, we try to maximize contact surface, and we also added autograft as shown on the fluoro image here. And to minimize the risk of ischiofemoral impingement and decrease the lever of the abductor arm, we try to avoid excessive medialization, although one might criticize this and say I could have medialized the joint a little more. So this is another example, 15-year-old female who had perthes at age 4, no prior surgery, and who comes with left hip pain. And so beyond the difficulty of the surgery, what can we anticipate her post-operative pain can be? So impingement in the context of a high riding trochanter and a coxa magna breva, and persistent groin pain may be due to labral pathologies, but also arthritis and poor congruency of the joint. So arthritis and some aspect of the joint congruency, there's nothing much we can do about, but we can, on top of the PAO, anticipate and decrease impingement as much as possible by adding a surgical hip dislocation here with a Gibson, with a relative neck length lengthening, an osteoplasty, and that also gave us the opportunity to address the labral pathology. And this was her 3 months post-op. So some of the potential pain generators can be also evaluated intraoperatively. This is a 40-year-old athletic female who had no interest in hip replacement. And so intraoperatively, after provisional fixation of correction, intraoperative testing revealed an anterior impingement, as you can show on the left. So we did an open capsulotomy with a femoral neck osteochondroplasty associated with subspine decompression. And that's the postoperative images on the right. And so back to famous Zoe. So this was a less challenging operation from a technical point of view. We thought intraoperatively there was not much argument for addressing the femoral neck. The only thing we didn't address is the pretty discrete labrum pathology that you see on the lower image. So we thought this was a reasonably executed PAO, and yet at 4 months, her pain persists and she has increased dysesthesia along the leg. All her aberrant manifestations are there. So at this point, what do we do? And this is where collaboration and having colleagues that share the burden is an important thing. So I turned to my sports surgeon colleague Mia Hagen at the university, and to ask her to evaluate the opportunity for hip arthroscopy. And consistent with the study showed by Dr. Millis, she found the labral pathology that she addressed. There was some room for osteochondroplasty. As Dr. Larson says, once you start looking, you can see potential signs of impingement, and she did take down adhesions at the capsulolabral level and extra-articular level. So 6 months later, I just saw the patient. She feels fine, apart from some tinglings and foot issues. This is not the last we see of Zoe. I think we all have Zoes who keep coming back, but this is a case where collaboration with a colleague was key in management. So this is finally another scenario where hip pain comes back after a long interval of a pain-free period. This is a 30-year-old female who had a bilateral PAO by Dr. Closey, followed by an implant removal, and she lived 2 decades with very little symptoms, and for the past 2 years, the right hip started to hurt, mainly posterior, little anterior, with intolerance to squatting and walking. And the problem here is we're probably not going to find one single identified cause that is treatable. And so the workup shows a little bit of everything, and that's always the problem we're confronted with. The examination shows a Duchenne gait, so weak abductor associated with lateral pain, impingement anterior and posterior, although I think those are very difficult to evaluate in the context of a hip that's going to hurt in all range of movement at extremes. Radiographically, on the AP, the joint space is reasonable, but on the Lequesne view, one can see a little pinching on the posterior inferior aspect. MRI, same thing, a little chondral thinning here and there, a degenerative labrum with cysts, and some ischiofemoral space pathologies with edema and questionable space, which we all struggle with for the definition and specificity of those exams. On the CT, there's no femoral torsion or tibial torsion anomalies that could be a single answer that we could address. And injections, both intra-articular image-guided and in the quadratus femoris space, had both partial and transient improvement. So in the absence of one single solution with predictable good prognosis, we thought that the management for postoperative pain, post-PAO, was temporization. And so PT addressed lateral pain, gait, and some aspects of ischiofemoral impingement by reinforcing abductors. We worked on spino-pelvic alignment with core, therapeutic injections to bridge over, which actually really helped trochanteric bursa and even origin of TFL, which in my observation anecdotally can be painful, and a 40-pound of weight loss combining calorie restriction and tirzepatide. So in the meantime, we communicating all through 2 years about the fact that contact pressures of the joint, as finite element analysis have shown, cannot be restored in hips despite a good correction. And there was a lot of understanding and communication about that, to the point where 2 years after successful temporization, she serenely took the decision to convert to a total hip replacement. And this is also where I found a very interesting importance of collaborating with arthroplasty surgeons who understand the hip dysplasia, so that patients do not get lost in the limbo and dismissed because of their young age and a deceptively preserved joint space on an AP X-ray. So the take-home message, what we call a well-executed PAO beyond a good-looking X-ray and technically well-performed steps, are about identifying patient-specific factors that could be the herald for the postoperative pain, acting on them prior. So the management is probably mostly done upfront. The importance, again, about partners and multidisciplinary discussions. And we have chat group, and I consult my colleagues, most of whom are here on a regular basis, to ask for their opinion, to communicate about non-modifiable items and patient education, so that they have reasonable expectations. And to answer the questions that we all ask ourselves, when is the good time to throw in the towel and pull out the trigger to start the conversation about conversion to total hip? One of the possible answers can be when all the actionable items have been checked out and at least discussed with the patient. Thank you.